Welcome to the Counselling Tutor Podcast, the must-listen-to podcast for students of counselling and psychotherapy. Here are your hosts, Rory Lees-Oakes and Ken Kelly.
Hello and welcome to episode 29 of the Counselling Tutor Podcast. And across the mixing studio desk is my good friend and colleague in all things counselling, Mr. Ken Kelly. How are you doing, Ken?
I'm very well, thank you, Rory. Absolutely delighted to be here. And I'm going to hit it right back at you and say, how are you today, Rory?
Very well, Ken. I have a cup of tea.
Or you see, now this is the how we differ as people and in our approaches, I guess, and because I've got a cup of coffee.
We'll have to start our own modality of beverage, won't we? I could be the psychodynamic tea drinker, and you could be the humanistic coffee supper, maybe.
Indeed, and we've got a great mixed bag, talking about mixed drinks in the episode today. Episode 29, we're going to be starting off speaking about PTSD. That's I guess a topic that comes up again and again and again, and it's not covered maybe in as much depth as it could be, and when it is covered, there's often conflicting ideas around that, so we're going to be having a look at that. Theory with Rory, a really interesting one today. We're going to be looking at the theory of Elisabeth Kübler-Ross. Can you give us kind of a bit of a taster, Rory, of what you're going to be sharing with us?
Yeah, I'm going to be sharing a model that's taught in a lot of counselling provision, a lot of counselling courses, called the DABDA model of loss and grief, which was pioneered by a Swiss American psychologist called Elisabeth Kübler-Ross. I'm going to discuss it, and it's not just one that's promoted within counselling courses. It's promoted in the healthcare profession in general, and I'm going to tell you a little bit about its history, a little bit of how it's useful, not just for grief, but for other losses, and also tell you a little bit about its limitations. It's come in for some criticism through the years, and I think that it'd be useful to know what those criticisms are, and a bit of a bombshell, why it's taught so widely. So we'll leave that till I give the theory.
Looking forward to theory with Rory today, and we're going to be closing episode 29 by going back to our roots. And Counselling Tutor, the Counselling Tutor Podcast, and our mother website, which is counsellingtutor.com, was started by Rory and myself to service students of counselling and psychotherapy, to kind of be there as you go through your training, as you go into your assignments, as you look at your theories and try and make that easier to understand, as you look at your skills and try and kind of give you some more depth of understanding around that. And we've got the handouts. And if you've been with us for some time, listen to our podcast, you'll know that that is our base foundation. So we're going right back to that base foundation today and looking at the overwhelm that you can face as a student during your counselling journey. It can at times be pretty stressful. It can bring up anxiety. There can be times where you feel that the way that your tutor is working is not fitting with you. And we're going to be talking about that today. And this is, of course, echoed, and all the topics that we discuss come from our Facebook group. And if you're not a member of our Facebook group, come and join over 4,000 fellow like-minded learners from around the world. And you'll find us, just go to Facebook and look out Counselling Tutor. And we'll let you in. We will indeed. But we're going to be starting off with PTSD. Kick us off for a starter for 10, Rory.
The starter for 10. Well, it's interesting that the term PTSD really only came into the lexicon of psychological language in the 70s, and it came into the lexicon of language after the Vietnam War, because lots of people coming back from Vietnam, having flashbacks, feeling stressed, becoming unwell, feeling frightened, anxious. And eventually the American Psychological Association, I think in 1977, put it into their big book of diagnostics, which is called DSM, Diagnostic Statistical Manual, which is used by psychiatrists to diagnose mental health illnesses. And it became known as PTSD, or post-traumatic stress disorder. But we can see reference to it far back in history. During the Korean War, it was called, and excuse the term, but it is a historical term, going Asian, because people coming back from the Asian conflict were finding stress. And during the Second World War, there's plenty of literature which mentions soldier's heart, which is a term for battle fatigue or shell shock, and lots were written about that. And of course, it's not only people in the military who get post-traumatic stress disorder. It is people who've been in very stressful situations where they believe that their lives were at imminent threat, and it's a debilitating condition, and it's in degrees as well, Ken.
It is, and I think it's really important that you've mentioned there, because we can often associate PTSD with people who have been in service, who have seen action on the front line, but it's not necessarily so. It can be presented in your clients that have gone through a traumatic episode within their life, and they find themselves going back there. And the thing with PTSD is that you feel the fear and the realness of that situation triggered in the here and now. It is the there and then that comes into the here and now, and it is a horrible, horrible thing to live with. And there is a chance that you may see this presenting within your counselling room. Are there any thoughts of how you might spot this, Rory, with somebody presenting in counselling?
Well, I think you bring up an interesting point, Ken. We have to be careful as counsellors that we don't diagnose. We are not psychiatrists or psychologists, or there will be some who will listen to this who will have done further qualifications to allow them to diagnose. So we have to be thoughtful that really post-traumatic stress disorder can only really be diagnosed by a psychiatrist or a doctor with mental health qualifications. However, we can see the broad strokes of it. It would be clients being triggered by something. So for many veterans, it's diesel, because a lot of military vehicles use diesel, and they smell diesel, and of course it takes them back to to fighting vehicles, fighting fireworks, bonfire night, explosions. In the UK, for those of you not in the UK, we have bonfire night. It's where we set off rockets, firecrackers, that type of thing. It's a kind of historic celebration of saving Parliament from being blown up. But the explosions can trigger it. In clients who've been abused, sadly, it can be seeing someone who looks like them, smells like them, certain situations, and occasionally it can just take people over with no particular reason. That doesn't really, in my experience, doesn't have to be a trigger, Ken. Yeah. Some people just walk down the street and all of a sudden they're not on the street, they're taken back to when they were younger or in a different place, not a great place.
Horrible. And I think what you've covered there is really important, is that it can be triggered, if we're talking about triggers, and not necessarily that it is always triggered, by all of your senses. It can be a smell. It can be a certain temperature, that you feel a certain temperature and it reminds you and takes you back to that place. And you're instantly transported, a part of your brain is instantly transported back to the fear and the fight, flight, freeze, flop situation, where you basically feel a life and death kind of situation, and it can come across you in a dream that you wake up in that situation. Really not to be wished on anybody, and a very serious condition. And I guess when we see this, if you haven't done any continuing professional development, you haven't studied this specific area, who might we be referring to, Rory, if we see this presentation or we suspect it?
Well, I think there's a couple of things here, Ken. If somebody's absolutely debilitated by it, then what we really need to do is make a referral back to their GP or their doctor, with their permission, and it is a tricky area. I have said to clients in the past, it feels to me, although I'm not an expert in this, it feels like you've got post-traumatic stress disorder. And for those who are, when I'm saying suffering really bad, I'm talking about people who can literally disappear for days on end and hide because they're so frightened. Then I would be asking with their permission to make a referral to the doctor. And I would write to their doctor, he or she, and say that maybe they need a psychiatric consultation, because there's different ways of dealing with post-traumatic stress. You can use drugs. You can prescribe drugs, which reduces anxiety. And also the National Health Service say that EDMR is now the preferred treatment for post-traumatic stress, which is rapid eye movement therapy, which effectively, and we haven't got really long enough in this podcast, although I have done a lecture on this in the CSR study resource. I've done 3 lectures on this. It effectively moves the part of the brain that activates the stress. It activate the EDMR activates a different part of the brain to manage the part of the brain that's giving you the stress. But let me share this with you, Ken, and I'm sure you might have seen this in your practice. One of the things when people talk about this is they sometimes, if they have no idea what it is, they think they're going crazy. Yeah. They think literally going mad, if I can use that slightly non-political correct term. Normalizing it is a big part of being a therapist. And I always say to clients who have this, your body's doing what it was designed to do. You know, when you're in a traumatic situation, that middle part of your brain, what's sometimes called the emotional brain or the limbic system, so there'll be lots of people Googling now, limbic system, is designing a strategy to keep you alive. The only thing is, it keeps you alive, but you have to deal with the consequences afterwards. So a big part of a therapist's job, I think, is normalizing it and saying what you're having is a reaction, but it is normal for someone in your situation. And you know, Ken, that can be such a relief for people 100%. Who think they're literally going crazy.
100%, and not feel so alone, not feel like they're the only person, because very often they will keep that secret, not wanting to share it with anyone because they think they are losing grasp of their sanity. So by normalizing that and saying it's okay, you're not the only one, and there is help out there, as you mentioned. EMDR.
EMR.
Eye movement desensitization and reprocessing. I'm reading this from Google because I was putting it in while you were saying it, Rory, just so I could get the words up there. And it's interesting because that's in the UK at the moment the preferred modality from the National Health Service. However, that changes from time to time as new research becomes available, and so it should. And I remember at one stage it was suggested that person-centered therapy is not good for working with PTSD because you basically asking them to talk about it maybe, and taking them back to that place was seen at the time as not preferable. However, I believe that has changed slightly as well, and that person-centered can be used in conjunction with other modalities. But I think what's really important is you need to train in this. You do not want to be going and messing around with this without the training.
As a rule of thumb, I think that if someone has that, there's no benefit at all taking people back to the traumatic experiences, because you're forcing them to confront the trauma. Now, some therapists would say that this is useful. Working with the feelings around it, getting them to talk about their experiences in their own pace, at their own way, in a way that feels safe. And I've worked with clients who've had PTSD type symptoms. They've talked about it, and just by talking about it, it's reduced it considerably.
Yeah.
So, it depends, I guess, on the depth of it. But they're still talking about it now. And there was an interesting program on Radio 4 this week saying that they're using a different model. They managed to start to map the brain a bit, and they think they can alter it by the use of rewards.
Wow. And it's interesting, isn't it?
Yeah.
How this all kind of, as the research comes in, so our understanding changes, and it just reinforces why we do CPD as a reflective and ethical practitioners, because you need to be keeping up with what's going on. And if you're interested in CPD and knowing more specifically around the brain, because you were speaking about the limbic system, Rory, and how the alarm center of the brain is set off by smells such as diesel, there is a phenomenal lecture that you did, Rory, on brain plasticity, and that is available in the Counselling Study Resource. Counselling Study Resource, if you are not aware what that is, it is a resource that Rory and I built to help students of counselling psychotherapy as they go through their studies. It's not a course in itself, it is there to help you with the course that you have at the moment, and we have live lectures twice a month. And if you're interested in that, just go to counsellingtutor.com. That's counselling spelled with 2 L's because we are based in the UK. Counsellingtutor.com. Right on the front page, right at the top, is a little banner there, and you can actually download the prospectus to the Counselling Study Resource, and it'll tell you everything that's in there, and you can have a look and see if that feels a fit for you. It is a paid service, but you can have a look and see if that is going to be a fit for you. So there you go. PTSD, definitely something worth considering, talking about, taking into your college, your learning institution, your university, discuss it with your peers. Come and speak about it more on the Facebook group, and that's Counselling Tutor. You'll find us on Facebook. So theory with Rory, really interesting today. Elisabeth Kübler-Ross, what are you going to be sharing with us?
Well, I'm going to be talking about a very popular model of understanding grief and the cycles of grief that was developed by a Swiss-American psychologist called Elisabeth Kübler-Ross. She wrote a book called On Death and Dying, and she did a lot of work observing people with terminal illnesses and how they came to terms with, their, once for a better word, demise. And she wrote it in a structure. And I'm going to be talking a little bit about the structure, a little bit about how it's still useful, but also talking about its limitations and really kind of a little bit of a bombshell, why it's taught so widely. People say, why is it the one that's always seems to be taught? And I'm going to give you my thoughts on why it's taught, not just only to counsellors, but health professionals across the spectrum. And it might be actually quite surprising when I tell you.
Well, without any further ado, let's go into Theory with Rory.
Counselling Theory with Rory Lees-Oakes.
Few theorists in the world of counselling and psychotherapy have made such a profound contribution to the understanding of grief, loss and death as Swiss-born psychiatrist Elisabeth Kübler-Ross. Born in 1926 in Zurich, Switzerland, to a Protestant family, from a very early age she developed a strong social and work ethic. During the Second World War, she became involved in refugee work in Zurich and later visited Majdanek concentration camp in Poland. On graduating from the University of Zurich Medical School in 1957, she married a fellow medical student. A year later, she moved to the United States, taking up residency in psychiatry. During that time, she undertook 39 months of classic psychoanalysis training in Chicago. As she began her training and residency in psychiatry, she was horrified at the way the hospital treated patients who were dying. To counter this, she began giving a series of lectures to students who work with the terminally ill to help them understand how patients may feel and experience the final stages of their lives. In 1962, she accepted a position at the University of Colorado School of Medicine, completing her training in psychiatry in 1963 before moving to Chicago in 1965. She went on to become a lecturer at the University of Chicago's Pritzker School of Medicine, developing a series of seminars using interviews with terminal patients to teach students how to care for those with a terminal diagnosis. She used these qualitative interviews to form her hypothesis on the psychological process of dying, which formed the base of her book, written in 1969, entitled On Death and Dying. Her theory became better known as stage theory, or DABDA. It outlined the psychological processes of coming to terms with the end of life in 5 stages. It also is used to help explain to clients the process they may experience when losing someone or something. DABDA is an acronym for denial. This is the first reaction. The first reaction is denial, where people disbelieve the loss of a loved one or the receiving of an end-of-life diagnosis. Anger. This is where the individual cannot hold on to denial. They become frustrated or angry at those close to them. They may say, "Why me? It's not fair. How can this happen to me? Who is to blame? Why would this happen?" Bargaining. This is the third stage. The individual hopes they can avoid the cause of grief. Usually some kind of negotiation takes place. Phrases like "I can change" or "I will alter my lifestyle." People facing less serious trauma will bargain or seek compromise. Depression. "I'm so sad, why bother? I'm going to die soon, so what's the point? I miss my loved one, why go on?" During this stage, the individual feels sadness and despair at the recognition of the loss to come. They may become withdrawn, refuse to see people, and spend their time feeling sad and upset. Acceptance. In this last stage, individuals come to terms with the inevitable loss. they become calm and retrospective, accepting the loss. Phrases such as, "It's going to be okay," "I can't fight it," "I may as well prepare for it," are common in this stage. Later on, Kübler-Ross expanded her theory to other forms of loss, such as relationships or those who are coming to terms with withdrawal from substance abuse. Although the model is widely accepted within the psychotherapeutic community, critics have pointed out a few flaws in the theory. It might not fit all clients, and they may experience the stages in a different order, miss some out, or not experience any of them. The stage model is prescriptive. It may be that some therapists try to rush the process or convince clients that they are experiencing a stage when they are not. The environment the client finds themselves in plays a role. If they are in a supportive environment, then clients may not experience some of the stages. The therapist may overlook the client's uniqueness of experience, focusing only on the stages of grief. One of the questions often asked is why this model is so popular amongst professionals in the caring professions. The answer may lie in some research undertaken by two of my students a few years ago while researching models of grief. They interviewed counsellors and healthcare professionals and discovered that the Kübler-Ross model was the easiest to understand by both professionals and the public, and could be taught from a handout and a brief explanation like the one I'm sharing with you today. Elisabeth Kübler-Ross died in 2004 in her home in Scottsdale, Arizona, and was buried at Paradise Memorial Gardens Cemetery. She'll be remembered not only for her pioneering work in the field of loss and grief, but as a founder of the hospice movement and for her pioneering work in caring for those with AIDS. Whatever the critique of her work, one area of her life is not in dispute. She changed forever the way professionals engage with those who are dying or suffering from the loss of a loved one.
Thank you, Rory. Really interesting as always. Denial, bargaining, depression, acceptance, it's all there. Dabda, and I believe we have a handout, and you can get that handout by going to today's show notes. You'll find those by going to counsellingtutor.com. Click on the podcast tab. It's right in the top menu. Just go to episode 29 and you'll be able to download your Dabda sheet there, and it's got it all laid out what Rory was covering today. And you know, the thing is, Rory, that's a really interesting topic, and grief is certainly something that we see again and again as counsellors, as psychotherapists. When you're in practice, you are going to have clients bringing grief at various levels.
Yeah, absolutely, Ken. And grief isn't just about death. You know, grief is about a loss of any kind. And, you know, in our work, we see losses of all sorts of times, loss of health, loss of relationships. You know, loss tends to be a theme that comes up time and time again. So this model is useful, but as I say, it does have its limitations.
You know what I'm going to do, Rory? I'm going to try and twist your arm live on the podcast, and I'm going to try and see if we can organise for maybe early 2017 that you might do a lecture for us on grief, on complex grief, because I know you've got an absolutely cracking lecture up your sleeve, because I've taken it.
Yes, yeah, I did a few years ago. I did a certificate in grief and loss, and yes, all right. My arm's been twisted up my back. Yeah, oh, that hurts, Ken. Stop it.
You see, all these good reasons to join the counselling study resource, and I can just hear the rubbing of the hands of the people that are already members as they look forward to that great lecture. I remember it, the group that I was in when I watched that lecture that you presented, Rory. You left a lasting impression with the information that was brought over. It was very eye-opening, and I'd been in practice for a good few years before I heard that, and it certainly still underpins my practice when somebody presents with grief at some level.
All right, well, can I have my arm back now, Ken?
You can have your arm back as we go on to the next part. And, you know, we're here for students of counselling, psychotherapy, and learning and studying counselling. It can be, at times, stressful. There are times when you might think of giving up. There are times that somebody in your group may really annoy you and you feel you can't go on because of somebody else in the group. There are times where you feel maybe your tutor is doing something that they shouldn't be doing. And it can be tricky, Rory. It's not easy. Apart from the study and the learning and the self-development and the skills you have to learn, there's all the dynamics, I guess, of what goes on within the learning environment.
Absolutely, Ken. And if I can reflect on my counselling journey, using a metaphor, it was a bit like learning to drive. You learn to drive your life in a car, and mine was a little 1.1 cc small car. And I started the world of counselling. It's like someone said, just come with me, just get into this Ferrari and put your foot down as fast as you can. And it really did for me feel like, with everything I was learning, the personal development, the theories, the having to adapt to work in a social care environment when I'd come out of a different profession, it felt like I was driving at really high speed. And I was grateful for my tutors who understood this and were literally in the passenger seat saying, it's okay, we'll just keep going and we will tell you or help you. And my supervisor sat in the back seat helping me along, and my colleagues cheering me on from the side, if that isn't too big a metaphor, Ken. But it can feel very overwhelming. And I'm sure that sometimes students feel that the tutors are a bit against them, Ken.
Mm. Yeah, it is. It's difficult. And you speak about having all that support. And I guess when you look back now, you can see that support was in place, because it is, while you're studying, you need the support of your supervisor. You need the reflection from your peers. You're also in practice. So when you are in placement, you maybe have the team, the management team within the placement. You have your tutor. It's quite a balance. And yours, when you look back, you think of them as standing cheering. And that was a great metaphor. And I guess for others, it doesn't feel like that. And I wonder what people can do to get through difficult times. And I say this because we see it on our Facebook group all the time, where people are saying, I don't think I can do this anymore. I want to leave. And it can be things like having an assignment referred. It can be a number of different things that come up. And I know from my journey, there were times where I felt, I don't know if I want to do this anymore. There are barriers that you face. And I guess there's times where getting through those barriers feels impossible.
Absolutely, Ken. And you mentioned referred assignments. There's nothing worse than having spent ages on an assignment, giving up your time, maybe not seeing your family. Yeah. You hand it in and it comes back referred. Or as a lot of people are saying now, criteria not met. And I do sometimes wonder if students think that, not to put too fine a point on it, tutors are doing it on purpose because they don't like them. I've heard that once or twice. Yeah. And the reason is, from a tutor's perspective, when we set the criteria isn't set by us, it's set by the awarding bodies or the universities we teach at, and we have to, as tutors, we have to justify to an external assessor who comes in at the end of the year what we've taught, and if what we've taught actually hits the program guidelines. And I think a lot of it is that it's like with everything, it's communication. Just go and speak to your tutor and say, look, can I have a tutorial, or can you spare me a few minutes? I understand that you're really busy, and heck, I know it is a very busy life being a lecturer certainly in a lot of colleges and universities. So always make the time to try and speak to your tutor. And the big thing is, if you're getting really overwhelmed, it might be time for your own personal therapy. It might be time for you to take that time and go and start on your own therapeutic journey and try and find out what's going on for you.
Yeah, definitely. And many awarding bodies, that is a prerequisite. You have to do your own personal therapy because they do recognize that it does get difficult at times. But I want to go back to what you said there, Rory, of go and speak to your tutor. If it feels like your tutor is against you, I can assure you they are not. They are so for you. It is the tutors are there. They go into this because they want to help you through. They want to get you over the finish line. But sometimes it is challenging because they face their own difficulties, like Rory, you've just brought there, and you should know you've done it for over 10 years. You know but if you go to your tutor and open a conversation and say, you know what, I'm really struggling, I want to speak with you, that's the way to go. If you're struggling with somebody within your group, go and speak with them. Have the courage, the openness to go and get it out in the open. Don't keep it inside you and carry it around and just hold it within self. Get it out. You also have your PD group. Take it into your personal development group. Get it out. Get it out into the open. Talk about it. Get it out of you. When it's internally held, it just goes round and round and round, and that story can go off in all kinds of different directions and gain its own momentum. When you bring it out into the open, it becomes real, and you can get the feedback, the support of your peers, of your tutor, and of course take stuff to supervision if stuff is coming up in practice for you, or speak to your practice manager. That's my big takeaway from this is speak. Don't keep it inside.
Absolutely. And to finish the metaphor of driving a different car, it took me a little while to realise that actually I was in the driving seat, and it might have been a different car, and it might have been a faster car, and it might have felt and handled differently, but I had a brake pedal and I could take my foot off the accelerator. Yeah. You know, I was in control of it. It was my car. It was a different vehicle, but it was my vehicle to control. And I sometimes think that's a useful metaphor. Yes, it does feel a lot different, but you're still the driver of it. So,
yeah, you know, and the other thing is,
road, just pull up at the side of the road.
Oh, I like that. pull into the lay-by, Rory.
Pull into the lay-by. Get a tea.
And you know, keep in mind that what you are learning is new information. Having assignments and deadlines, potentially holding down a job while you're doing your studies, potentially being in practice, and potentially having to go to supervision, and potentially also having to key into your own counselling. It's a lot. It is a lot. But it does come to an end. It does come to an end, and I'm going to stick with the metaphor of the driving, Rory. Eventually, it becomes like driving a shift gear car. Eventually, you don't have to think about it so much, and you can change gears without having to think, oh, clutch in, change gear. Yeah. It does get easy. Stick with it. And you know, I think that it is good. I think that it is good that this is a challenging course, that not anybody can just walk in and say, oh, I'd like to be a counsellor, because here's the thing. Special people become counsellors because you're there to do a really special job, and you're going to face resistance. And you have always said, Rory, I remember you saying it right at the beginning of the courses for new learners coming in, counsellors are not made, they are forged. And they are forged in having to face those barriers and overcome them because, hey, that's what you're going to be expecting from your clients when they sit in front of you. So be easy on yourself. Pull into that lay-by, as Rory says. Have yourself maybe a flask of tea if you're in a lay-by, and be fair to yourself, and just keep on going.
Just enjoy the ride.
Yeah.
Just enjoy the ride.
Well, this is episode 29 of the Counselling Tutor Podcast, and what an episode it has been. We started off speaking about PTSD, going on to some great theory from Elisabeth Kübler-Ross, looking at, of course, grief there, and then looking at our journeys as counsellors, as psychotherapists, as we're studying that overwhelm, the barriers and the resistance that we might face as we go through our journey.
Yes, so as we come to the end of this episode, bearing in mind what we've just talked about, as always, stay grounded and stay safe.
Take care.
Thank you for listening to the Counselling Tutor Podcast. Find the show notes for this episode on our website at www.counsellingtutor.com.